Everyone, our subject today is headaches in pediatrics. Basics. Headache is a pain in the head involving the intracranial content, skull or scalp. Primary headaches, no underlying conditions like migraine, tension headache, cluster headache, and anatomic cephalgia. Secondary headaches, symptomatic specific cranial, oral, dental, or cervical pathologic process like tumor or trauma. Headaches are common and usually benign. Parents often seek medical attention for a child because they are concerned about the potential of a serious or life-threatening cause of headaches. Most headaches complaints will be primarily headache disorder. Evaluation is essential to rule out more worrisome secondary causes of headache. History. Clarify temporal pattern, location, duration, and intensity. Also, time of onset, associated symptoms, precipitating and ameliorating factors, response to therapy, and family history. The following question should be asked: is there more than one type of headache? How are they different from each other? Since they started, have headaches gotten worse or stayed the same? How is the pain described? Pounding, squeezing, stabbing, or some other descriptions? Do the headaches occur at any special time of day? Do they wake the patient up? What does the patient do during the headaches? Does the patient have idea about what is causing the headaches? Migraine is acute recurrent headache. Nausea, vomiting, photophobia, phonophobia, and transitory neurologic disturbance suggest migraine. Agitation, pacing, and loud crying are atypical for migraine and more consistent with the cluster headache. Tension type headache usually present as a chronic or episodic non-progressive headache pattern. Pain often bilateral, band-like diffusion, dull, non-pulsatile, and of mild to moderate intensity. Mixed headache pattern, migraine superimposed on tension headache. Red flags: first or worst headache, occipital location, recent headache onset, increasing severity or frequency, headache in the morning associated with vomiting, headache causing awaking from sleep. Ask about common comorbidities, motion sickness, allergic rhinitis, depression. 70% of those with migraine have a family history of migraine, especially those with the migraine with aura. Tension type headache is associated with a higher rate of divorce, parent, and fewer close friends, unlike migraine. Physical examination, vital sign, especially blood pressure and height and weight. Obesity, consider pseudotumor cerebri or sleep apnea syndrome. Skin changes consistent with the neurocutaneous syndrome. Patient with neurofibromatosis commonly experience headache. Auscultation for bruit over the supraclavicular area, neck, and temporal and occipital area. Arthritis, vascular malformation. Examination for sinus tenderness, limitation of jaw excrusion, or occipital trigger points. Fundoscopic examination, the presence of venous pulsation, best seen at the origin of branch points of the veins, decreases chances of intracranial hypertension. Visual acuity exam may reveal eye strains-related headache. Neurologic exam should be normal in primary headache syndromes, migraine and tension headache, except during a migraine with a prolonged aura or migraine variant. Stiff neck, head tilt, decreased alertness, abnormal eye movement, asymmetric deep tender reflex, asymmetric motor weakness or sensory deficit, ataxia, and gait disturbance may signal infection, stroke, hemorrhage, tumor, or demyelination. Migraine without aura criteria in children, 5 or more headaches attack that are at least 1 to 72 hours, have at least two of the following: bilateral or frontal in 2/3 of cases, or unilateral, frontal temporal location, pulsating or throbbing quality, moderate to severe intensity, aggravated by routine physical activity. At least one of the following accompany headaches: nausea and or vomiting, photophobia and or phonophobia, may be interfered from behavior. How to approach to child with headache after performing history and physical examination. Is it severe acute? If it is yes, is there history of recent trauma? If it is yes, perform head CT scan or MRI with or without cervical spine film. Differential diagnosis: acute post-traumatic, post-concussion headache, intracranial hemorrhage, other head or neck injury. If patient has no trauma, feature suggestive of migraine present. If it is yes, perform neurological exam. If it is normal exam, consider neuroimaging if negative family history for migraine. Differential diagnosis: migraine without aura. If it is abnormal neurological exam, perform neuroimaging. If it is normal, this is migraine with aura. If it is abnormal, differential diagnosis: tumor, abscess, hydrocephalus, cyst, vascular disorder, intracranial hemorrhage, stroke, arteriovenous malformation, other intracranial vascular disorder, Chiari malformation, optic neuritis, low CSF pressure. If the patient has no criteria for migraine, if there is abnormal neurological examination or history of neurological symptom, if it is yes, perform neuroimaging as we mentioned. If it is no, ask about fever. If there is no fever, differential diagnosis: tension type headache, cluster headache, and other type of headache, a primary exertional headache, toxic effect of substance or their withdrawal, caffeine, cocaine, food additives, disorder of hemostasis, cold stimulants, ice cream headache, other cranial neuralgia, hypertensive crisis. If patient has fever, is there meningeal signs or altered mental status present? If it is yes, perform lumbar puncture. If it is abnormal, differential diagnosis: meningitis, subarachnoid hemorrhage, vasculitis, encephalitis, infectious, acute disseminated encephalomyelitis, ADEM, or autoimmune. If it is normal LP result or patient does not have meningeal sign or disturbance in conscious level, differential diagnosis: viral or bacterial illness, meningism, abscess, tonsillar abscess, retropharyngeal dental abscess, sinusitis, other infection, ENT, and cranial structure. This is in cases of severe acute headache. In cases of acute episodic headache, is there features suggestive of migraine? As we mentioned, if it is yes, this is migraine with or without aura. If it is no, patient does not have feature of migraine. Is there abnormal neurological exam or history of neurological symptom? If it is yes, consider CT or MRI. Differential diagnosis: migraine with aura, third ventricle cyst, cluster TAC, vasculitis, childhood periodic syndrome, migraine precursors. If it is no, patient does not have abnormality in neurological exam or history. Differential diagnosis: tension type headache, toxic effect of substance or their withdrawal, caffeine, food additives, craniofacial abscess, infection, sinus, dental infection, refractive error, uncorrected or miscorrected, primary exertional headache, seizure-associated headache, occipital cranial neuralgia. If it is a chronic headache, chronic non-progressive headache, differential diagnosis, chronic migraine, chronic tension type headache, a new daily persistent headache, idiopathic intracranial hypertension, caffeine withdrawal, carbon monoxide poisoning, other toxic effect of substance or their withdrawal, temporomandibular joint syndrome, analgesic rebound, infection, abscess, chronic post-traumatic, post-concussion, headache, vasculitis, primary CNS, angiitis of childhood, infection-related, conversion disorder, hypoxia, occipital neuralgia, and Chiari malformation. If it is chronic progressive, perform CT or MRI, differential diagnosis, tumor, hydrocephalus, idiopathic intracranial hypertension, subdural or epidural hemorrhage, aneurysmal leakage, rupture, arteriovenous malformation, abscess, cyst, arachnoid, epidermoid, dermoid, third ventricle, Chiari malformation type 1. Red flag. Symptoms that require urgent attention include headaches that wake a child from sleep, early morning vomiting without nausea, worsening headache, associated personality changes, or neurological symptoms. Be aware that frequent headache, including migraine, may be caused by emotional, sexual, and physical child abuse. Basilar migraine presenting with vertigo, diplopia, blurred vision, ataxia should be differentiated from posterior fossa tumor. Headache associated with the other neurological symptoms is common in brain tumors, but headache may be the only symptom in some brain tumor. In an infant with the cerebral hematoma, child abuse should be considered. Children may present with the irritability, vomiting, bulging fontanelle, and focal seizure. Fundoscopy may show retinal hemorrhage. Neuroimaging is urgent. Remember that MELAS may present with the recurrent migraine-like headache. Migraine are the most likely recurrent headache disorder to present with the first acute severe headache. Other chronic or recurrent headache disorder will more commonly present for evaluation after repeated episodes, even if they have not quite reached the diagnostic 3-month duration criteria, but may need to be considered in the evaluation of any first severe acute headache. MRI is generally preferred for identifying structural lesions, infection, inflammation, and ischemia. CT is preferred in acute cases of suspected trauma or fractures. Imaging choice should consider that head CTs carry a higher radiation risk, whereas MRI are more costly, time-consuming, and they require sedation. Headaches developing within 7 days of head trauma with the sign or symptom of concussion are defined as acute post-traumatic headache. Migraines are classically characterized by a positive family history for migraine, associated nausea, vomiting, or abdominal pain, sensitivity to light and sound, an aura, scotoma, blurriness, visual distortion, sensory changes, or other transient neurological disturbance. Relief with sleep is common. Triggers, stress, fatigue, illness can often be identified. Migraine can be unilateral or bilateral in children, and the pain is typically characterized by pounding or pulsing quality. Whereas a longer headache duration and unilateral location become more common with increasing age. Neurologic deficit like hemiplegia, vertigo, visual changes may occur with some of the less common subtypes. Many experts consider the absence of a family history for migraine as a risk factor for space-occupying intracranial lesions in children with acute headaches. Be cautious that migraine presentation can vary between family members, and headaches are often unrecognized as migraine by family. Detailed questioning may be required. Most experts recommend neuroimaging for the child who has migraneous headaches with an absolutely negative family history of migraine or its equivalent, motion sickness, cyclic vomiting. The second edition of International Classification of Headache Disorder provides detailed diagnostic criteria for several subtypes of migraine. Diagnosis of migraine disorder require at least 2 episodes meeting the diagnostic criteria. The classification includes migraines with and without aura, including hemiplegia and visual disturbance, as well as childhood periodic syndromes. Neuroimaging (MRI) is preferable if available, is warranted when the neurological examination is abnormal or unusual neurological features occur during the migraine. When a child has headaches that awake him from or her from sleep, or that are present on first awaking, then remit with the upright posture, or are very brief in duration, occurring only with the cough or bending over. Brain tumor present with the symptoms due to increased intracranial pressure or focal destruction or invasion of brain tissue. Presentation vary according to tumor types, location, and patient age. The increased intracranial pressure typically causes a headache that may wake a child at night, are typically worse in the morning, are aggravated by coughing or bending over, and are frequently accompanied by vomiting. Papilledema, 6 nerve palsy, altered level of conscious, and gait instability may also be noted on examination. An increased risk of brain abscesses is present in children with the immune deficiency disorder, right to left cardiac shunt, especially tetralogy of Fallot, chronic ENT infectious, ear, sinus, mastoid, dental, penetrating head injuries, soft tissue infection of the face or skull, and infected VP shunt. Hydrocephalus is most likely to cause headaches in older children whose cranial sutures are closing. Headaches are generalized. They may be acute or gradual in onset and mild or severe in quality, depending on how rapidly the hydrocephalus is progressing. Third ventricle cyst may function as a ball valve mechanism, causing intermittent severe thunderclap headaches due to transient increase in intracranial pressure. Other cysts like arachnoid, epidermoid, dermoid may present with the progressive headaches or seizure. Neurologic abnormalities, altered mental status or meningeal sign, knuckle rigidity, kerning, and Brudzinski warrant an evaluation to rule out meningitis. The risk of increased intracranial pressure must be considered before performing a lumbar puncture, although this risk in children is low. There are no specific guidelines regarding imaging before performing an LP in children. Clinical judgment should take into consideration factors such as presence of papilledema, focal neurological deficit, a history of hydrocephalus, a VP shunt, or history of neurosurgery or cranial space occupying lesions. Headache often accompany fever of any cause. Headaches can frequently be caused by systemic infection, influenza, sepsis, and extracranial infection, ear, eye, mastoid, as well as a cranial infection like meningitis and encephalitis. Meningism describes symptoms consistent with the meningeal irritation, but due to infection of the other head and neck structures rather than meningitis. Tension type headache are the most common headaches experienced by children. They are typically described as having a squeezing as opposed to pounding quality and band-like non-focal distribution. They can be episodic or chronic. They tend to be less severe and they have a shorter duration than migraines. Triggers, stressor, fatigue can frequently be identified. Neurological examination is always normal. Mild sensitivity to sound or light may occur. In chronic cases, mild nausea may occur as well. Trigeminal autonomic cephalalgia, TAC, are characterized by headache and parasympathetic autonomic features and are rare in children. Like all headache classification, they can be acute or chronic. Cluster headaches are comprised of acute severe attacks of unilateral pain around the temple or eye with associated ipsilateral rhinorrhea, sweating, eye redness, tearing, eyelid swelling, pinpoint pupil, or ptosis. Others in this category: paroxysmal hemicrania, short-lasting unilateral neuralgiform headache attacks with the conjunctival injection and tearing, present with the similar but less severe symptoms. Neuroimaging is usually recommended in these cases to rule out possibility of a more serious causes. A primary exertional headache can be triggered by exercise or exertion in people who do not suffer from migraines. It can last from minutes to hours and is clearly precipitated by exercise. Imaging to exclude an intracranial hemorrhage is recommended for the first occurrence of this headache type. The International Headache Classification Disorder 2 encompasses headaches attributed to exposure to or withdrawal from a variety of substances within the single classification. Examples include medication, drugs of abuse, carbon monoxide, caffeine, and food additives. Definitive diagnosis cannot be made until significant improvement is documented after the exposure to the substance has ended. Disorder of homeostasis encompasses problem with the blood gases, hypoxia, volume distribution, blood pressure, and endocrine disorders. Examples include headaches occurring due to altitude changes, hypertensive crisis, or fasting. Evaluation should be based on clinical presentation. Stimulus or irritation of the various branches of the cranial nerves cause pain in the area that those branches innervated. Cold stimulus like ice cream and compression like tight headgear or helmet are causes of trigeminal, glossopharyngeal, and occipital neuralgia pattern are recognized. No convincing association between mild and moderate hypertension and headaches has been demonstrated, an acute severe headache may occur with a rare hypertensive crisis. Headache may be a component of childhood periodic syndromes, which include cyclic vomiting, abdominal migraine, and benign paroxysmal vertigo. Neurologic findings noted during episode, like nystagmus, visual disturbance, are completely absent between episodes. These syndromes are considered childhood precursor of migraine. Migraine type symptoms during hemicranias epileptica and after seizure are a well-recognized entity. Chronic headaches are defined as occurring on more than 15 days per month for a period of at least 3 months. The category of a new daily persistent headache encompasses new headaches without an identifiable cause, in particular medication overuse, that are occurring daily from within 3 days of their onset. This type of headache is usually bilateral with a mild to moderate severity. It may have features of either migraine or tension type headache, but no more than one of the following characteristics: photophobia, phonophobia, mild nausea. The appropriate onset is critical to making this diagnosis, which can only be applied after 3 months of headache. If a patient cannot describe this type of onset, this term should not be applied. Idiopathic intracranial hypertension, previously called pseudotumor cerebri, can present acutely but is more commonly diagnosed as a cause of progressive headache. It is most common in young obese women. There may be a history of an enlarged blind spot and constricted visual field. Papilledema is usually present and a 6-nerve palsy is common. Otherwise, the physical examination is typically normal. Vomiting is infrequent. Neuroimaging is normal. However, it must be preceded an lumbar puncture in order to rule out intracranial processes. The CSF studies are normal except for an increased opening pressure, and the LP typically provide relief of the headache. Intracranial hypertension can also occur secondary to a multitude of etiologies, including metabolic, infection, hematologic, and drug-related causes. Temporomandibular joint syndrome causes pain localized to the temporomandibular joint. It is aggravated by chewing motions and associated with the clicking sound. Medication overuse causes headache in patients taking analgesic daily or on most days. It often complicated other headache types. The headache occurs due to vicious cycle of pain and analgesic use, sometimes inappropriately dosed, followed by more pain and more analgesic use as the effect wears off. The definitive diagnosis cannot be made until improvement is documented within 2 months of stopping the medication overuse. The term probably medication overuse headache is appropriate until then. Post-traumatic or post-concussion headaches are described as chronic when they persist beyond 3 months. Chronic post-traumatic headaches frequently occur as part of the broader post-traumatic syndrome, which includes more problems with the balance, sleep, cognitive function, mood, etc. A neck injury, like whiplash, may cause similar chronic symptoms. Cervical spine films with or without neuroimaging should be done acutely in a case of whiplash. Subsequent neuroimaging may rarely be indicated to rule out chronic subdural hematoma. Thank you for your listening.